We will now begin with a quiz that will be conducted by Dr. Anaka Kulkarni, who is an associate at the Pediatric and Hematology Department of Sir General Alliance Hospital. Thank you for that. So now that we've all had lunch, we should stay awake and be a little more interactive. So we'll have a quick quiz. It's an interactive quiz where everybody is participating. It's going to be held online. So I request everybody to just get their phones out and go to Google Chrome or Safari or whatever and type kahoot.it, KAHOOT.IT. So once you type that, you will get a screen where you can enter this game pin. So we'll just wait for a couple of minutes for everybody to join. If anybody wants to scan, you can also scan this QR code. So for the nickname, you can put your initials or something which can identify you. Okay, so we have quite a few people in. We have 26 people. Is anybody left to join or shall I start? Because once I start, you will not be able to join it. For all the virtual delegates with us, you can also join the quiz if you wish to. However, prizes will be there only for in-person attendees. 27 people with us. 35. Okay, so we are 35 people. So 5 people left. If you can't scan, just type kahoot.it. Okay, great. We have 30 people here. Yeah, waiting. Done? Okay. Let's begin. So we've had a couple of interesting sessions about thalassemia management and sickle cell management. Let's see how much we know and test our knowledge. Whichever questions are difficult or have not yet been covered will be covered in the subsequent talks. So let's begin. So are you all ready? Keep your phones ready. 3, 2, 1. Let's begin. So what is the most pronounced underlying pathophysiology of transfusion-dependent thalassemia? Is it hemolysis, tissue hypoxia, ineffective erythropoiesis, or iron overload? You can tap on the color on your screen and the time limit is visible on the screen. Okay, so the correct answer is ineffective erythropoiesis, which is the most important pathophysiology. Going on to the next question. What is the lab criteria to define transfusion-dependent thalassemia? Is it hemoglobin less than 7 gram% on 2 occasions, 2 weeks apart, excluding other causes? Or is it less than 8 gram%, 2 occasions, 2 weeks apart, excluding other causes? Or is it less than 6 gram% even once with hepatomegaly, excluding other causes? Or less than 7 gram% on 2 occasions, 4 weeks apart, excluding any other causes? You have 20 seconds to answer. So we have 26 answers, 28, 29, 30. I think we have to. Okay, so the correct answer is red, which is less than 7 gram% on 2 occasions, 2 weeks apart. This is to define the transfusion dependency. So now we know that there is transfusion dependent thalassemia and non-transfusion dependent thalassemia, which require transfusions less frequently. So to categorize somebody as transfusion dependent, if the hemoglobin falls less than 7 gram percent with and on 2 readings 2 weeks apart, then that person is a transfusion dependent thalassemia. Going on to the next question. Okay, Dr. ABC is leading. Whoever is ABC here. What is the most common beta thalassemia mutation seen in India? IVS 15G to T, IVS 15G to C, 619 base pair deletion, or codon 15 mutation? 5, 4, 3, 2, 1. Correct. Most of y'all have gotten confused between C and T. So it is G to C, not G to T. We heard in the prior talks by Dr. Roshan ma'am as well that IVS 15G to C is the most common. Going on to the next question. A 7-month-old with severe microcytic hypochromic anemia and hepatosplenomegaly presented and received an emergency blood transfusion. What would be the next best step to diagnosing? Is it to send an HPLC immediately? Is it to give iron and discharge and investigate on follow-up? To send parental HPLC or to do a reticulocyte count? Okay, we have 31 answers. You have 10 seconds to go. Right. Correct. So most of you all have got it right. Parental HPLC would be the next obvious best step to diagnose these patients. Next question. In transfusion-dependent thalassemia, a pre-transfusion hemoglobin should be maintained at what level? Is it 8 to 8.5 gram percent, 9 to 10.5 gram percent, 12 to 14 gram percent, or is there no need to maintain any pre-transfusion hemoglobin? Great. So majority of us know what it is to maintain the pre-transfusion hemoglobin. There is no point of doing a post-transfusion hemoglobin, as we all know. So pre-transfusion is very important. Going to the next question. Which is the only IV ion chelator available with us? Is it Asundra, Deferasirox, Desferrioxamine, or Deferiprone? 5, 4, 3, 2, 1. Great. So desferrioxamine, as we know, is the IV ion chelator. It was the first ion chelator which was available to us. Now, because of oral drugs available, it is the oral drugs are preferred as the first choice. Okay, so Dr. ABC is still leading. Great. So what is the gold standard for assessment of liver ion overload? Is it a T2 star MRI? Is it liver biopsy for liver ion concentration, serum ferritin levels, or a fibroscan of the liver? Great. So most of you all have got it right. T2 star MRI is done more frequently. However, books say and guidelines say that the gold standard would be a liver biopsy. It is more representative of the entire ion overload in the body. So next question. Abnormal TCD velocity was defined as a maximum velocity greater than or equal to dash centimeter per second in the MCA. I'm sure everybody would get this right. We've just had this lecture. Okay. So normal is less than 170, abnormal is more than 170. 170 to 200 is conditional, and more than 200 is when you actually act and do something. So next question. Which ion chelator removes cardiac ion better? Deferasirox, desferrioxamine, deferiprone, or Asunra? Five, four, three, two. Great. So deferiprone or Kelfer is the one which removes a cardiac ion better. So identify the HPLC report I'll be displaying. If it's not very visible, I'll just read it out. The HbF concentration is 1%. HbA2 concentration is 4.6%. Is it thalassemia major? Is it normal? Is it a trait? Or is it HbE beta thalassemia? Need two more people to answer. Great. So this is HbA2 level high is thalassemia trait. All of us know that. Great. So after 10 questions, Dr. ABC is still leading the scoreboard. Dr. Burhan and CPD are closely behind. Last five questions. If two thalassemia minor patients have a child, what are the chances of having a thalassemia trait child? Is it 25%, 50%, 75%, or 100%? With two people left. Okay. So it is 50%. I've asked thalassemia trait and not thalassemia major. So each pregnancy, there is a 25% chance of having a thalassemia major child or a 25% chance of having a normal child, whereas 50% chance of having a trait. Going on to the next question. All of the following are endocrine complications of thalassemia except hypothyroidism, hypogonadism, diabetes mellitus, or precocious puberty. We've just had this lecture too, an extensive one by Dr. Abhishek. Brilliant. So yes, delayed puberty is what happens and not precocious puberty. Okay, Dr. CPD is now leading. Very good. Okay, PCV13, PPSV, meningococcal and HIV vaccines are to be avoided in sickle cell anemia patients. True or false? Two more people to answer. One more person. Easy questions, no? Who said true there? So these are to be given in sickle cell anemia patients. They undergo autosplenectomy. The splenic function is abnormal. So we have to vaccinate them against encapsulated organisms. So these are to be given in sickle cell anemia patients. Okay, next question. Transfusion-associated GVHD, a fatal complication of blood transfusion, can be prevented by what? Is it leukoreduction, using blood filters, irradiation of blood, or using partially HLA-matched blood from relatives? We've had two wonderful lectures about blood transfusion from our blood bank specialists. Okay. So the answer is irradiation. Leukoreduction does not prevent transfusion-associated GVHD. Blood filters does not help. And using partially HLA matched blood is what actually is more prone for causing a transfusion associated graft versus host disease, because the recipient does not recognize that as foreign, and then the T cells would go and engraft in the marrow and cause a graft versus host disease. So irradiation is the only mechanism which can prevent a TAGVHD. Irradiation should be recommended in all immunocompromised bone marrow transplant patients, Hodgkin's disease patients, and other certain primary immunodeficiency patients as well. Coming to the next question. The last question of the quiz. Which of the following can also potentially be used in the management of thalassemia patients? Is it thalidomide? Is it luspatercept, gene therapy, or all of the above? So all of the above. Thalidomide has shown great promise. Luspatercept is also upcoming with various clinical trials showing promising results. Gene therapy is still far, but yes, potentially is a cure. So yes, all of the above can be used. So on third prize, we have Dr. CM. Who's Dr. CM? Anybody here? Who's there? Second prize, we have Dr. Burhan. Very good. And first prize, we have Dr. ABC. Who's Dr. ABC? Not revealing your name there. There is no ABC. Okay, let's check the. Is it a virtual participant? Can we check? Person doesn't give prize. Okay, great. So we'll be giving off the prizes later. So online. Okay. So we'll check who's the fourth person here in person and give that person the third prize. Okay. So thank you so much for your active participation. I hope everybody is awake and not sleepy post the delicious lunch. So we'll go ahead with our next session. And I request Madeline to announce.
For our next session, I call upon our chairperson, Dr. Pankaj Panik sir, who is a consultant pediatric at Chelation Reliance Foundation Hospital and also a mentor. Yes, sir. Thank you, sir. I also request you, sir, to introduce our next speaker, Dr. Swapnil Kenny.
Good afternoon, friends. I'm sure it is tough to attend this post lunch. And I have a privilege to introduce Dr. Swapnil Kenny. So the reason that it's not very common for an orthopedic surgeon to speak in hematology conference, right? But I think this is very nice because he specializes in managing complex musculoskeletal conditions in children, including those arising from a chronic hematological conditions such as thalassemia and sickle cell disease. Dr. Kenny has contributed extensively to advancing the understanding and surgical management of bone complications in hemoglobinopathies and advocate for early orthopedic intervention to improve quality of life and prevent long-term disabilities. As we have seen different managements in thalassemia and sickle cell anemia regarding the blood transfusion, the chelation, the monitoring, including hepatic function, pancreatic function, cardiac function, and bone density. So many things we monitor in thalassemia patients because of urine transfusion. But this is the first time probably we have a speaker who speaks on a subject which is not very commonly touched and we are not very commonly thought about in thalassemia patients. May I request Dr. Kenny to please.
Thank you very much, Pankaj Parekh sir, for the generous introduction. Uh, at the beginning, I would like to thank Shweta Bansal ma'am and all you stakeholders who are doing a wonderful job as regards the treatment of and management of thalassemia. Let me congratulate you on this wonderful job. My brief today is to basically speak about the musculoskeletal manifestations. Unfortunately, my slides may not be as scholarly as the preceding speakers who've been here, but I'll try and compensate them with a few pictures and videos, which may be of a bit of interest to all of you all. Now, the flow of my lecture is essentially going to be this. We will look at the bony manifestations in brief, not in details. Pathological changes in the bone, which as clinicians and physicians, you are aware. Radiology, we had a wonderful lecture in the morning on MRI, so I'm pretty certain that you know everything about it. As regards management, again, let me be very candid. Usually, most of these do not need surgery. There are very specific indications, and I shall be speaking about those. So we know it's a group of inherited disorders. There is profound anemia. There are safe transfusion practices, and you've been the trailblazers as regards the treatment. And of course, we now see a lot of these children, unlike when I was doing my residency, that they are now getting into adolescence and adulthood. Now, let's look at the bony manifestations. We are basically going to be looking at the osteopenia and osteoporosis, fractures, bone pains, intervertebral disc changes, spinal deformities and cord compression, and of course, probably the most important rare phenomenon, which is the avascular necrosis, about which I'll be going a bit into detail. Now, osteopenia, osteoporosis is a multifactorial and a multimodal reason in thalassemia. Essentially, it's a combination of chronic anemia leading to marrow expansion, causing a lot of compression on the cortical surface. In addition, blood transfusion, iron overload, causing vitamin D deficiency, at times diabetes, hypogonadism, and hypercalciuria and renal tubular issues. All these lead to a low bone mineral density. Now, similarly, because when you have a low bone mineral density and at the same time you have vascular occlusions, you can have an osteoporotic process leading to what we call as pathological fractures. Beta thalassemia is known to have a lot of pathological and many a times subclinical fractures which are not seen on X-ray. You may need to get advanced imaging like an MRI, wherein you can actually see the marrow edema and you can see an early insufficiency fracture rather than a complete cortical break. So when you get children coming to you with severe bone pain, with some amount of swelling, inability to move the extremity or the joint, you need to think of a possible pathological fracture if your X-ray is looking normal. You can either immobilize them and do some amount of immobilization therapy empirically, but if you really want to investigate them, then MRI is the investigation of choice. It can pick up these what we call as insufficiency fractures. Bone pain again is similar. The trabecular bone levels go down, the cortical bone thins out, and there is a lot of multifactorial, multimodal issues, especially sedentary behavior, secondary to all other issues, can lead to bone pains. Now, intervertebral disc issues essentially are caused by bone marrow proliferation, which causes cortical thinning, resorption, and certain medications which can cause a flattening of the spine known as vertebra plana. And essentially, when the normal marrow is replaced by abnormal marrow, you get what we call as the low signal intensity appearances on T1 and T2. So if you can see this MRI, on the one side is the normal MRI and the other side is the MRI of a thalassemia patient. So you can see the difference between the two. Spinal deformities are quite common, especially low-grade kyphosis, low-grade scoliosis, curves usually less than 10 to 15 degrees. Most of them, as I'll be coming in the next few slides, don't really require much. Avascular necrosis is probably one of the leading causes of disability in patients with thalassemia and other hemoglobinopathies. Essentially, two mechanisms have been postulated. The first is a recurring hypoxia secondary to periodic blood transfusions and a hypokinetic flow of blood through the posterior circumflex artery, which is the main artery of the proximal femoral epiphysis. The second thing is the osteopenia and the osteoporosis, which makes this particular femoral head a lot prone to what we call as insufficiency fractures or compression fractures purely because of stress. And both these things can cause a compression of the trabeculae, leading to reduction in the trabecular blood flow, leading to avascular necrosis. Now, if you look at management of osteoporosis in thalassemia, this is a Cochrane review, essentially, which picked up multiple studies. And what they found, as what Dr. Abhishek also mentioned, is that bisphosphonates may increase the BMD, especially around the femoral neck, lumbar spine, and forearm. Again, as I said, you need to look at the Z scores and not the T scores, and you have to mismatch them with the age of the patient, the weight of the patient, and the skeletal age. So all these things need to be matched. Zinc is an important supplement because it is known to increase the BMD. That is what they found from this Cochrane review. And denosumab really doesn't have much of a difference. Neither does strontium. So probably their role needs to be investigated more in the future. Fractures, luckily, though they are caused by trivial trauma, luckily most of them are closed, undisplaced, minimally displaced, which unite with conservative management, don't really require any form of a surgical treatment. Bone pains, again, is very well described as to how you can treat them. You can do pre-transfusion, you can basically raise the threshold by giving, do a pre-transfusion exacerbation can be reduced. Surgical, very, very limited treatment is required. Pharmacological, again, NSAIDs, you can give bisphosphonates, physical therapy, rehab, all those kind of things. Now, spinal issues is something which is very, very important. And there are two particular important pathologies which you need to be aware of. The first is extramedullary hematopoiesis, which can cause spinal cord compression, causing neurological deficit. And the second is deformities. Now, essentially, deformities are not much of a problem, but spinal cord compression is an issue. It can either be a vascular because of reduction in blood flow to the spine or an actual compression like I'm going to show here. So this is some amount of hematopoietic tissue which is forming in the spinal canal, causing compression of the spinal cord or the dural sac, leading to neurological deficit. And the treatment here, unlike any other form of compression, is non-surgical. It is essentially medical management, which may include either transfusions or it may include radiation. So both these things have known to be extremely beneficial in the treatment of such patients. Very rarely does one need to do a spinal decompression, and that is also not without risk. So one needs to be careful there. Scoliosis, again, low intensity curves can be managed with the medical line of management. Coming to the last part, avascular necrosis, which is essentially what my interest is. It essentially probably happens because of avascular necrosis. As I said, there are two mechanisms. And what one needs to understand is that if a child comes to you with avascular necrosis below the age of 8 years, right, then it is possible for you not to have the complication of avascular necrosis, which is arthritis of the hip joint, provided you keep this particular hip well inside the socket. So let me explain what I'm coming to. Okay, avascular necrosis basically causes collapse of the femoral head. Now, if you imagine this is the acetabulum and this is the femoral head, when there is a collapse, it loses the sphericity, the femoral head, and it actually tends to move out of the acetabulum. When that happens, when it tries to move out of the acetabulum, there is significant compression from the edge of the acetabulum on the femoral head in a child below 8 years, causing severe deformation of the femoral head. Now, the concept of bioplasticity is that in an AVN, if a spherical head, despite collapse, remains inside a spherical socket, it will remodel provided the child is less than 8 years of age. If it still collapses and still remains inside, it will still remodel because it will again become spherical over a period of time. But if it collapses and goes out and remains out, then whatever you do, unless you put it inside surgically, it will remain outside and cause early arthritis. So that is what the concept of bioplasticity is, and this is essentially in children below 8 years of age. Now let's look at this particular case. This is a patient with a left-sided collapse, avascular necrosis. As you can see, the epiphyseal size is smaller. There is a lateral subluxation of the femoral head outside, right? And this is a young child. So again, it is a spherical hip, but it has gone out. As I said, if you put this hip inside, it will remodel and take the shape of the acetabulum. That is called as containment surgery, which I'm going to be showing. And if it is an aspherical head and it still remains outside, you can actually augment the acetabulum and make it a little more roomy by doing something called as a coverage surgery. Now, how do we manage these AVNs? The first thing we do is we put a dye inside the joint and we look for three things. One is that whether there is a congruency between the acetabulum and the femoral head. One. Second, if the femoral head is inside or contained or it's outside. And third, if it's outside, what is the level of coverage of the acetabulum over the femoral head? Now, this is how we do an arthrogram. This is the hip which has gone outside. I am going to be injecting a dye there, and all of you can see. Now, why do we inject a dye? Because you cannot see the entire head. It is not yet ossified. But to see the entire cartilaginous head, you need to inject dye. So when I inject dye, you can see that the femoral head is much bigger than what it actually looked on the X-ray, right? So I have put my dye there. Now I remove the needle and I move this head through the entire range of motion. This is a sterile procedure. It is done in the OR. And you can clearly see that this is a completely spherical head despite the collapse. So the collapse has happened in the bony part, but the cartilage is still intact, right? So this is a hip which is subluxated but spherical. Means that the ball and the socket both are spherical. The ball is slightly moved out of the socket. And what we are going to do is we're going to try and put this ball inside the socket. And how do we do that? We do that surgically. So again, coming back to the case, this is the patient, the right side, there is a subluxation. And we do, that is the X-ray, that is a CT scan again. It's quite an old case. That is where you can actually see it. So I actually do a little bit of abduction and see in how much of abduction the ball goes inside the socket. Because in neutral position, the ball is outside. So what I'm essentially going to do is trying to put the ball inside the socket. I'm going to actually abduct the proximal part of the femur so that the proximal part remains in abduction and the ball goes inside the socket. This is the standard lateral approach which we use for a lot of hip fractures and hip pathologies. Essentially, to get you back to your anatomy, that is the tensor fascial lata which I cut. That is the vastus lateralis there. I'm going to open it up. This is quite a quick video, just to give you a perspective of how we do it. So that is the vastus lateralis which I'm cutting. I'm putting an L-shaped. I'm elevating it, exposing the lateral part of the femur. That is the periosteum, thick periosteum in a child, which you may have heard of, but probably seeing it for the first time here. Raise it. Now that is a lateral femur. Okay, I'm going to mark the trochanter there. This is my greater trochanter. Right? Now, I basically need to put my ball inside the socket, for which I need to abduct the proximal part of the hip, and I'm going to do it with a procedure known as a varus osteotomy. I'm going to give a varus to the proximal femur, right? So I'm going to put a couple of wires. The distal wire is essentially for the rotational part of it, because what you tend to do is tend to keep the compressed part a little away from the side where there is maximum pressure. So those are my wires. I'm going to mark my osteotomy because I'm going to have to cut this bone to open it up. I'm also going to use what we call as a compression plate there. I'm going to bend it so that my bone conforms to the level of my plate. So that is where we are. Now that is how my plate will look, because I am going to abduct the proximal femur and I'm also going to incorporate my trochanter there, right? So I have done my osteotomy. I am now going to cut the bone. That is what I do. Okay, and as you see, when I'm raising this periosteum, you will see what happens. Now you can see this is completely open and the proximal fragment is abducted. I'm going to put a plate there. And this is what is called as an open wedge osteotomy. I'm going to fix it with screws, bone screws. And now you can see the ball is inside the socket completely. It was out. Now it has gone inside, and that is abduction, adduction. And that is your final X-ray. Now, many a times you can have a healed, what you call as AVN, where the ball has remained outside the socket. And once that happens, it actually impinges on the lateral wall of the acetabulum and causes a lot of stiffness. So how do we manage that? Again, we do that dye thing we call as an arthrogram. You inject the dye inside and you see what is happening. So if you see here, the lateralmost part of the femoral head is impinging on the acetabulum. And that is the part which needs to go if you need to get good range of motion. So that is the part of the femoral head which is outside and which is not allowing it to go inside. So that is where we are. That is the impinging part. And I'm just going to remove that impinging part. It is the non-weight bearing or non-loading part. And once I do that, you can see that now the ball goes very well inside the socket. Right? So this is called as osteochondroplasty, where you remove a part of the femoral head to make it more congruent like this. If you see on the first X-ray, there is a bump. The bump is excised, and that is the femoral head, which is not exactly spherical, but it is definitely better, definitely more functional. So to summarize, essentially, the treatment of thalassemia, including bone complications and bone issues, is predominantly medical. Most of the other issues can be managed either with medications or a combination of medications, rest, and physical rehab. The role of an orthopedic surgeon is very, very limited in thalassemia, though maybe a little more in sickle cell, probably because we see more avians there. But as and when the role is needed, one needs to be very, very active in treating them, being aware about what all is possible, what all can be done, so that we can improve the quality of life of these children. It's not only about how many years they live, it is about the way they live and whether we can keep them pain-free and disability-free till the time they are on this earth. Thank you so much.
Any questions, Dr. Shakti? So then there is a question from a pediatrician. See, we normally maintain vitamin D level in pediatrics because, nutritional defects and osteopenia and C. So we try to maintain around 30, level of 30. So do you need to maintain vitamin D at higher level for better bone health in thalassemia patient?
I suppose it's quite a difficult task, but it's again a combined effort of an orthopedic surgeon and an endocrinologist. But yes, probably a higher vitamin D level would be a better option in a thalassemia patient.
Because we have heard orthopedic surgeons sometimes talking about maintaining vitamin D level at 70 to 80, so that they have much better bone growth, less complications with musculoskeletal system.
That is what the optimum suggested levels are as per the endocrinologist. Up to 17 children
17
is what is optimal.
Yeah.
For an excellent lecture. So I would like to ask you regarding avian theory. When we see the avian in thalassemia patients, we don't see it so common as compared to the patients where they are on steroids and adolescent on leukemia therapy. So is there a difference between the two, the kind of avian we see in thalassemia as compared to what we see in the steroid, post-steroid therapy?
I think it is essentially similar. Only thing is that usually if the child is younger, then the possibility of revascularization remains higher because there are 3 vessels which supply the pediatric femoral head, unlike one which supplies the adolescent femoral head. So that is one part. If you pick them up early, you can manage them better. Second is, again, avascular necrosis on its own is not really something which we should be concerned about unless they go into arthritis. So the idea is essentially we need to prevent them from getting into arthritis. And there are many what we call as hip preservation procedures now, including one is the VDRO which I showed, and even things like distraction osteogenesis or cases where we actually do a hip distraction to allow cartilage to grow. So avian per se is not really something which will cause pain. Avian causing collapse, leading to a misshapen femoral head, leading to a mechanical kind of friction between the acetabulum and the femoral head. Again, in children, because the cartilage is thick, they actually start developing pain later. But if we can pick them up early, we can still do a lot of hip preservation procedures. So similarly, in the other category of patients, if we can pick them up early, we can do a lot of hip preservation procedures.
How to do the screening? I mean, the patient is not complaining about the pain, and they are walking normally also. So is there any benefit of getting the screening done? Because screening is only MRI.
Absolutely.
If there's anything else which you can do by screening. So is there any exercises or any movements which you can see or a routine?
I think clinical examination, the first sign is loss of abduction and internal rotation. That is the first sign. So if you have asymmetric loss of abduction and internal rotation, then definitely an MRI is mandatory. If they have full range of motion, so you can ask them to sit on the floor. And if they're able to sit on the floor, get up, squat easily, then mostly things are fine. But if you do find any discrepancy or bilaterally there is a reduction in abduction or sometimes even a minor change in gait, which the parents will pick up. If that is so, then definitely they need to be screened. And yes, you correctly said that MRI is the diagnostic modality of choice.
Yeah, there are no more questions. Professor, his excellent presentation. And thanks for touching an aspect of thalassemia management which not very commonly have. And we thank you very much for your nice, beautiful presentation.
Thank you. Thank you.
Thank you, Dr. Swapnil, and thank you, Dr. Pankaj, for joining this session. We now move ahead to our next session. For this, I call upon our chairpersons, Dr. Fazal Nabi, who is a consultant pediatric at Jaslok Hospital, and Dr. Mihir Vora, who is a consultant hepatologist at Sir Richard Alliance Foundation Hospital. Our next session, the speaker for our next session will be Dr. Aarti Pagaria. She is physically not present today here, but we have her session recorded, which will be played now. Can we have Dr. Fazal introduce our speaker?
Dr. Aarti Pagaria is the first pediatric hepatologist in India, graduated from Delhi. And I know her since many years. And now she has joined Reliance Hospital. And within few weeks of joining Reliance Hospital, she has done 2 successful pediatric liver transplants. And even in few years, I was associated with her. We have done many liver transplants globally. She's excellent in pediatric hepatology management, and the way she approaches, especially during complications of post-liver transplants, at that time we should be a person who is stable enough to manage the complication. She is excellent. We can test listen to her and post presentation. If any doubts, we can just discuss that.
A very warm good afternoon to each and everybody present here, respected dignitaries, faculties, and dear delegates. My heartfelt thanks to Dr. Shweta Bansal and the entire team for giving me a topic which is hepatic complications and management of hepatitis B and C in hemoglobinopathies. And I apologize to be present online. I would have loved to be meeting you all in person, but because of some pre-commitments, I had to be present online. I hope in the next 20 minutes, I will take you through a journey of understanding how to improve the outcome of these children who develop hepatitis B and C infections while on treatment for their hemoglobinopathies. To start a topic like this, we have to understand where India on the globe for hepatitis B is. So we, as a country, we are in the low intermediate range for hepatitis B prevalence. For hepatitis C prevalence, we are in very low zone. However, because of the sheer number of patients that we have and the population that we have, 7 to 8% of all our chronic liver disease children without hemoglobinopathies also are the ones who are related to hepatitis B. The data for hepatitis C is not very wide or even available for children who are less than 18 years. However, when I looked at the topic and when Dr. Shweta gave me this topic, it gave me a hybrid into getting these two topics intermingled and then understanding the pathophysiology and giving an outcome which is definitely going to improve these children. So the various studies in which we have understood how hemoglobinopathies and the liver disease are evolving, it has been shown that as the number of transfusion increase and when people divide them into different transfusion groups, of course, the more number of transfusion, the higher incidence of hepatitis B and C you will have in these children. Also, as you grade children according to their ages, the ones who are older will definitely have a higher incidence of hepatitis B and C in those children who are suffering from hemoglobinopathies. Having to go through multiple data which came out where they have found hepatitis B and C and try to understand all with their some caveats in one study or the other, but finally the things which are very easy to understand and also an important point to be noted is that when we are looking at hemoglobinopathies and liver, apart from they just having hepatitis B and C, there are other processes which has affected that liver initially. For example, when I say that the liver injury ranges in any child with hemoglobinopathies from a minimal or to mild liver dysfunction with no clinical consequence to even somebody having a liver failure. And the four major reasons for these, I can list them as one, because of the high incidence of sickle cell anemia, the sickling process itself. That sickling process makes acute hepatic vaso-occlusion, has hepatic sickle cell cholestasis, have liver ischemia related injury, as well as the reperfusion injury, which happens once the flow is restored, hemolysis associated with this, and cholelithiasis. So, in a disease which has a sickling process, all these actions take place apart from iron overload and apart from if they get hepatitis B and C. The second, of course, is our chronic viral hepatitis, which we will be dealing in the rest of the talk. Transfusion-related hemosiderosis is definitely causing, and thanks to iron chelation, things are better for other organs. However, liver is one which has to go a long way for them. And we have some cases where the autoimmunity is also raised up to a higher level in these children. Unfortunately, they have to bear the brunt of it as well. So to summarize, definitely in hemoglobinopathies, iron chelation has modified the life expectancy of thalassemia patients. However, it has caused a decrease in death due to heart disease, but there has been an increase in liver disease. Prevalence of cirrhosis has ranged from 10 to 20%, and the incidence of hepatocellular carcinoma in thalassemia patients is progressively increasing in different populations. And when I say that sentence, it is important to understand that these kind of statements have come from studies which have longitudinally for a longer duration followed children who went on to become adult, and then they have these outcomes. An additional important point is that hepatitis C eradication has led to a marked improvement, demonstrating a synergistic action between the effect of antiviral therapy and iron chelation. And we cannot undermine the significance of treating it. Now, coming close to only children with what burden of hepatitis C we have, I told you India remains in the low incidence, and we have, at every point of time, approximately 3.2 million children and adolescents who are suffering with hepatitis C. The ones with hemoglobinopathies are a part of this. How does a natural infection of hepatitis C go? There will be around 20% who will have spontaneous resolution, and somewhere from 60 to 80%, and rather it's always on the higher side. Approximately 80% will go on to chronic infection. As the years go by, when we see from this, it will increase the hepatic complication in terms of fibrosis, in terms of cirrhosis, and even decompensated liver disease. And when we look at the natural course of these children, it is important to understand that majority of the spontaneous clearances usually used to happen in those who developed a perinatal disease. However, when we talk about hemoglobinopathies, these are those children which acquire infection later in life, and it has been shown that the liver disease develops in around 32% of all the patients with hepatitis C with a median age of 33 years and irrespective of the mode of infection. And the disease outcomes were always better in patients who were treated before the development of advanced liver disease. And this is the opportunity which we as pediatricians have to give to our population so that we do not allow them to have persistence of the virus replication when they enter into their adolescence and early adulthood. The beautiful thing is the evolution and treatment of hepatitis C has been lovely, and in the last 5 to 6 years, it has really changed the landscape. We had started the FDA approvals and the European Medicine Agency approvals for directly acting antivirals for these children from the year 2016, and the major boom came when they were approved for children as young as 3 years. So now we have an armamentarium of the drugs which are used for children for hepatitis B starting at 3 years of age, which has changed the entire scenario. We hope that we will reduce adults who remain hepatitis C positive, give it as transmission to their partners and then to the children, and then develop disease themselves, and each hepatitis C adult is giving another 4 hepatitis C positive adult and children. That has to stop now. So in the HCV drug armamentarium, we have the directly acting antivirals. What it means is that the hepatitis C virus has 7 non-structural proteins. Now they have been directly acting on these non-structural proteins. They belong to 3 groups: the protease inhibitors, which always end with the name of Previr; the non-structural 5 inhibitors, which have Asvir at the end of their name; and 5B, which are polymerase inhibitor with the suffix of Buvir. And this is a combination of these drugs which have changed and improved the outcome. We always have to use them in combination of 2 groups. The drug should not be of the same group because the same group has cross development of resistance. However, when we have 2 drugs from 2 different groups, we give a very high resistance to a very high protection to developing resistance to these drugs. And these are the sustained virological response that has been documented in children as young as 3 years when they are started on directly acting antivirals. They have ranged. The sustained virological response means that we have documented that once they clear their virus, they do not reactivate their virus once we give the treatment for 12 weeks in majority of them, in 24 weeks in few special situations. And the directly acting antivirals have beautifully shown sustained virological response consistently across the studies, ranging from 88 to 100%, which is way higher than what ribavirin and interferon was giving, to a tune of around 58%. So these are the directly acting antivirals for children with the recommendations approval. It is important that we do not use ribavirin these days except in decompensated CLDs, where on special circumstances it is being added to the DAs. However, children with hemoglobinopathies do not use ribavirin because ribavirin causes hemolytic anemia and worsens the outcome. So we have to then tailor-make the treatment according to that child. Apart from that, all the other drugs, which are a combination of two DAs from two different groups, have given beautiful results. They have got approvals from the American Association of Study of Liver Diseases, in the infectious study of the Infectious Society of America, as well as from the European Union. When we talk about, and the most important drug between them, as for our understanding, would be a combination of sofosbuvir and ledipasvir, sofosbuvir and velpatasvir, and glicapravir with pribintasvir. These are the drugs, and I'm showing you the common side effects for children, which are nothing major. Even for adolescents who end up developing more of constitutional symptoms, there is nothing major, they're only mild, and the discontinuation rates of DAS has been extremely, extremely low. Till now, there have not been a single child which we have treated and we had to stop the drug, and if they have not achieved. So, to summarize it, hepatitis C management in children and adolescents, including those with hemoglobinopathies of all kinds, all children must be aged more than 3 years, must be treated using pan-genotypic directly acting antivirals. The three names are informed, regardless of the disease state. Even if their LFT is normal, even if their fibroscan is normal, even if their ultrasound is normal, even if they have no liver disease, they should still be treated once they reach the age of 3 years, because that is the only way we are going to do the best to these children. Now, moving on, in the interest of the time, I will move on to hepatitis B. And though hepatitis B is itself a very large topic which can be spread over a month as well, but for this conference, I would like to put it that this is the different incidences of hepatitis B that have been seen in different studies of children in India with liver diseases. And you understand that more than hepatitis C, hepatitis B is much more common in general population. And if the same child has an hemoglobinopathies, because it also has a high prevalence, our work is increased. And this is a natural history of hepatitis B. The ones who have perinatal, of course, the risk of chronicity is higher than the ones who develop disease by horizontal transmission, and all the hemoglobinopathies will be under the horizontal transmission. However, as they go, the seroconversion rates are variable. The seroconversion rates also depend on the genotype. It also depends on a lot of other factors that the child goes through. And hence, whenever we have major studies, we should never be saying that hepatitis B will not cause liver disease in children. Even in a normal child, it can cause. And think about a child who has hemoglobinopathies, who has hemosiderosis, who has many other things associated that we mentioned. Of course, those children are at much higher risk of developing fibrosis, cirrhosis at much younger ages in much more severe population. If I have 10 children with no hemoglobinopathies with B and C versus a child with hemoglobinopathies, I have no business to deny this child of hepatitis B and C to not go through rigorous monitoring to identify that the opportunity of treatment for hepatitis B, for hepatitis C, irrespective of anything, they will be treated. So we have children, young children also, who show fibrosis, who show cirrhosis. There had been even 9-year-old children coming with hepatocellular carcinoma, which are children who are not suffering from hemoglobinopathies. So of course, children who suffer from hemoglobinopathies, we have to be extremely cautious. And this is the spectrum of chronic hepatitis B. If I have to tell you, in the entire, if I have 100 children, how many of them are likely to be immune tolerant, taken into consideration the age at which they got the infection, depending on what age they are now, and all these factors make us understand that the majority of the children at any point in time who are with the chronic hepatitis B will be in the immune tolerant stage, because it it is longer. It comes into the pediatric population. By the time they enter into seroconversion, they start becoming either later adolescent or adults. So this is exactly what I meant, that the spectrum till which we see, some may not give us even a window of adequate treatment, but some may give. However, until unless we open our eyes and test them and actively look for when they're giving us an opportunity, we will not be able to identify this. However, once they leave our clinics at 18 years, look at them. Many of them develop hepatocellular carcinoma, decompensated cirrhosis, and this is per year. 3 to 5% will develop cirrhosis, then decompensated cirrhosis, and finally they will have bad outcome. All this because they were suffering from hepatitis B. So in this study, if I tell you, and this is still, we have documented them as within the pediatric population, that despite the consideration that nothing will happen to a child during childhood if he is suffering from hepatitis B, which is wrong. They do develop cirrhosis, they do develop HCC. Which one will develop, which one will not develop? Do we have a window to treat? Who should we treat more aggressively is a question which needs constant monitoring. To make it simple, I would say that initially, long back, since many decades now, we had been understanding of how DNA, hepatitis B, of the hepatitis B DNA and our body's immune system reacts, and when should we treat and when should we not treat. So the previous nomenclature has now been changed from immune tolerance, immune clearance, and occult infections to the new one where it is only based on the E antigen positivity or the E antigen negativity, but in correlation with what is the ALT level. Is it normal? It is not normal. When it is normal, we call it only infection. When it is abnormal, which is more than 2 times upper limit of normal, and it is persistently abnormal, then we call it hepatitis. We also look at the DNA load. We then also look at the necroinflammation in the biopsy and then decide whether it is the time for this child to be treated. At the same time, in children with hemoglobinopathies, what is their status? What is the status of hemosiderosis? What are additional insult that we are expecting are something which will change our outcome. So when I go back to this, we understand that the first stage, which is the E positive infection stage, previously called as immune tolerant, they do not need treatment. Again, the inactive carrier state also do not treat treatment. It is when the body is trying to clear the virus is the point when we introduce drugs for hepatitis B so that we support the body's attempt to clear the virus. And they're going to clear and suppress the virus, not cure it. So it is very important to understand when we get this window and when we get this window again, but this most of the time this window is in the adulthood. So, or some children may be more than 15 years roughly, or 14-15 years depending on the mutation in the virus, and some pre-core mutations, they will come into this. But for the majority of them, and for better understanding, the hepatitis C drugs have to be given when we have these children coming at a time when the body is trying to clear them. And why I said it, because I'm very careful when we see children with hepatitis C, any of us for that matter, we should know what not to do. For example, this child came surface antigen positive. And then the next thing, somebody sends a DNA and E antigen, and this comes as a AST-ALT, which is normal, positive E antigen. Of course, this antigen is positive and a high DNA load. And the child was already started on tenofovir since 2022, which was 2 years from now. But why? The child was not in the stage where he should have been treated. This should not be done. This is another child who was surface antigen positive, E antigen negative, but E antibody not done, and a DNA copies which were low. Even this child was started on lamivudine. That is what we should not be doing, because we were treating the first child in this phase, we were treating the second patient which I showed in this phase, where there is no treatment required. We are doing two harm. One, we are giving the child a treatment which has no outcome at that time. Second, we are, for how long are you going to treat this patient? 15 years, 20 years, how many years? What about the side effect of the drugs? What about developing resistance to these drugs? And we have hardly 3 drugs in pediatric population which we are going to give to these children. Hence, before starting hepatitis B in treatment, I very strongly recommend that until unless somebody who has been treating them for many years, children with hepatitis B, we should not be brave enough to just start the drug just because we know the dose and we just know the FDA recommendation for cutoff of the ages. So these are the drugs which are available to us in routine use, which is entecavir, which is available after 2 years, tenofovir disoproxil also after 2 years, and the tenofovir alafenamide, which is after 12 years. Apart from there, we have lamivudine, which we can give to children more than 3 years of age. But more important is when to give, how long to give, do we need to give, do I need to look at any other determinants to decide? So overall, the entire discussion is beyond the scope of this talk. However, E-positive adolescents and children with a persistent ALT elevation of 6 months, and this is just not this, the other factors we have to see. E-negative adolescents and children with persistent ALT elevation for at least 12 months, those with even with moderate to high DNA levels, but moderate necroinflammation or fibrosis on the liver biopsy will mandate treatment. There is mild inflammation and fibrosis, but there is a family history of hepatocellular carcinoma. They mandate treatment. So all these indications which get extrapolated, keeping the concept same, keeping the baseline information and the knowledge that we have derived over these years by landmark studies in hepatitis B, and then we treat a child with thalassemia when they suffer from hepatitis B. So this is a very busy slide showing multiple ways to do, when, what we do, what we look at the DNA, we look at multiple other factors, and finally decide on whether we are going to give the child treatment or not. And why do we think that if really it is such a big botheration, why are we really bothered? We are bothered because we are going to give these children enter into adulthood where they will rapidly go into new other stages. Every year, some segment of these hepatitis B positive children will be developing HCC with to a tune of almost 2% every year from all the segments, from immune clearance phase also, even those with inactive carrier state, even those with reactivation, and they will also be developing cirrhosis from 2 to 4% of them every year will develop cirrhosis. So this is what needs to be modified by a very clear and a very systematic approach when we have children with hepatitis B, when we treat them, because in adulthood they are all going to go through these stages. So we have to understand where we want to bring those child at that point. And lastly, coming to the last few slides, whenever a child with Hep B and Hep C come with hemoglobinopathies, these are the important things we have to do. We have to understand the replicating markers which will determine my decision to treat the child. What is the liver parameters? What is the fibrosis? Do we need to screen them for HCC as well? But more important than this, at the first evaluation they come, please ensure that you check the anti-HIV total or check the vaccination history, do the family screening and co-infection screening. These are important both for hepatitis B and C. So at last, I would say that all cases with hepatitis B infection require lifelong monitoring. Once it has entered in the body, the virus never goes away. There is no cure for hepatitis B as of now, only control is possible. Most children with hepatitis B do not require treatment. They require expert wait and watch policy. But when I say most, I do not mean all. We have to see which one requires wait and watch and which one should be given. Contrary to this, all children with hepatitis C mandates treatment and it will lead to cure. Hepatitis B and C has a risk of progressive liver disease during childhood as well, and hence we should have lifelong monitoring important for them starting from when they were detected. Whenever we should always send a surface antigen, anti-HCV and anti-HBs in all the children with hemoglobinopathies. We should never miss an opportunity to vaccinate against hepatitis B, even with the coverage that we have, because the birth dose coverage is 40 to 55% in the country right now, and the 3-dose coverage is 86%. Plus, there are many factors in which we need a much higher anti-HBs levels, and for some reason they would not have shown that response. Both B and C are lifelong diseases, and expert referral and monitoring at the beginning is important so that we do not overdo and we do not underdo. Thank you very much. I will be more than happy to help any of these children in our liver clinic for young children at SRH and Reliance Foundation Hospital. And thank you all very much for your listening. Thank you.
Any questions?
Provided your joint full time. So if you can tell us like regarding for the HPV management. So Dr. Aarti Pavaria very clearly said that we should not be managing the patient on our phone. So can you elaborate on that? Because now when we get the HPV report and we know that we can start the recovery, it's not having much side effects. So majority of the family girls is that like we should start it. So what are the do's and don'ts over here?
So, ma'am, very well said. Entecavir doesn't have much side effects. The most commonly we see is lactic acidosis, and we should not forget entecavir and lactic acidosis. And that's why mandatory for us that whenever we treat, we always see lactate before starting any therapy. Which basically what I'm saying in admission. Majority cases, there are three, four things what we do is we keep on observing HGOT-PT reports repeatedly. Try to do every month initially, then 3 months, at least for a year. Watch the HPV DNA. For E positive, our cutoff generally is more than 20,000, and for E negative, our cutoff is 2,000. There are three guidelines broadly as adult hepatologists. What we will follow is APASL, EASL, and our ASLD. All of them have slightly different cutoffs for HPV DNA, but prima facie everybody's role is simple that we don't want young children being a pediatric conference that we suspect them to take medicine for 30 years, 40 years, 50 years. Out of the guidelines what madam mentioned, one thing was important is family member who has died because of liver disease has to be given, even if it is a child. We want them to take hepatitis B medication because the same virus must have entered the system through vertical transmission, and that has high risk of causing chronic hepatitis, cirrhosis, HCC. So death in the family is also important, not just HCC. In our adult guidelines, there is very much specific mention that death in the family because of HBV infection. So there are so many younger individuals who come to us and say their parents have died because of hepatitis B. They are not certain, but they know there was cirrhosis, very HCC, or decompensating event requiring a transplant, which they could not do and died. They are very careful in such individuals to start hepatitis B treatment. Barring these indications, as Madam said, as well as Dr. Aarti said, they are very careful. The use of fibroscan has helped us. We don't want to miss F1, F2 also. So anybody who's F1, F2 with rise in your enzymes, progressively monitored, as well as you are sure that the DNA values are higher as per the targets, E antigen more than 20,000, E antigen negative more than 2,000, you would be discussing about starting therapy. But more careful is, will the patient come for follow-up? Will he not take medicine for 6 months, 1 year, and not come for follow-up, and then again you'll be missing them? That is a big challenge in our population. And cost is important. And that's how at Sion Hospital, the National Viral Hepatitis Program, medication is available for free. So that also has to be understood by all of us that many people will come and say that we cannot afford. All pharma companies are helping us in this regime. They are giving at very less cost, helping us in doing DNAs very regularly for hepatitis B and C. And our national program is at forefront, helping us in giving even free for many people. So you want to?
No, pediatric population I hardly see coming for a liver transplant with hepatitis B and C. Even after a good screening mode, they have started in 2012. Hepatitis C in the blood donors 2012.
2004 was when we are bang on that we need to start.
So that since that time we hardly come across transmission-induced hepatitis B and C. But more than that is a primary disease, and then transfusions, therapeutic agents, and plus on top of it, transmission-induced infections, which causes the complication. But as a pediatric intensive care, we see a lot of patients coming with the metabolic liver diseases, but not a hepatitis B and C landing for hepatitis.
Thank you.
Thank you, Dr. Fazal, and thank you, Dr. Hindi, for sharing this session. We now move on to our final session for the day. For that, I would like to call upon Dr. Sanjeev, who is a consultant pediatrician at Chelation Foundation Hospital, and Dr. Gokul Bole, who is the Chief Medical Officer at Grant Medical College. Thank you, sir. I would now like Dr. Gokul to introduce our next speaker, Dr. Sujata.
We have a speaker, Dr. Sujata Sharma. She is an additional professor in pediatrician, in charge Division of Pediatric Hematology, Oncology and BMT, Lokman Network Municipal Medical College and Hospital Science. Over to you, ma'am. She has a lot of presentations also, for 126 presentations and national and international publications. Over to you, ma'am.
Thank you, chairpersons and Dr. Shweta, for inviting me to give a lecture on this topic. I think all of you are awake, alert to listen, because finally, when we diagnose, we have to finally treat the case. And we have not, we have reached to the stage of treatment and then transplant maybe. So we go on to the topic today is challenges in chelation and splenectomy in thalassemia. Okay. We all know why iron is required. That's a source of oxygen carrying capacity, which gives oxygen to the to every tissue through hemoglobin. Each unit of blood, each bag gives 200 milligrams of iron. So, what I want to stress is, on an average, in a thalassemic child, when he receives on an average 150 to 250 ml of blood annually, then the amount of iron which is deposited is around in the range of 0.3 to 0.5 milligram per kg per day. So the bag which we give Paxels is of a hematocrit level of 65 to 70%. It's never 100%. Okay. So when we say the blood is requirement less than 150 ml per kg annually, then he may be the iron deposition will be around 0.3 milligram per kg per day, and more in the patients who require more transfusion. So why this calculation is required, you all know, because deposition of iron causes all complications. Just now we heard all through the day what all cardiac complications, endocrine complications, liver complications occur in patients of thalassemia with add-on transfusion transmitted infections, which is adding for the liver toxicity. So basically, body doesn't have any mechanism to remove iron, as like how we have water-soluble B12 and everything, B complex and all. So iron cannot be removed in body unless you are going to chelate. Now this iron chelation, irrespective of in thalassemia, basically irrespective of total iron in the body, the amount of iron available for iron chelation is very limited. Why? Because most of the iron which is getting deposited in the tissue is not the one which is chelated. It is basically the labile pool which is required to be chelated. So when iron stores are markedly elevated, chelation of a prolonged period is required when high doses of chelators are used. Iron deposition in the heart is much more, responds very slowly as compared to liver and ferritin. Therefore, when the iron is deposited in the heart, it is always a very advanced stage of iron deposition, and therefore ferritin and liver iron can be removed easily. But cardiac iron requires a little more effort to be taken for iron chelation. And chelator binds to the level. Just now, as I said, chelator binds to the level pool, and this effect lasts as long as the iron chelators are there. Means what? The iron chelators are to be given lifelong for a prolonged period of time to act, right? And there are 3 to 4 different types of drugs which we'll be discussing. Desferal, as we know, it provides protection for as long as the infusion is on. Once you stop the infusion, the effect is gone. Kelper, as you know, the protection rate is not more than 3 to 4 hours, so you have to give more frequently. And XZ, I use XZ because all DDT is there, they pronounce very oddly. So XZ, that is Dephera Cyrox, provides protection for 24 hours, so we use once in a day. So what are the main aims of our chelation? Mainly is the maintenance therapy. Supposing we have a new thalassemia child who has been started, we all know the iron chelation has been started after how many transfusions? Just to make you aware. How many transfusions, after how many transfusions can we start iron chelation? On an average, 10 to 12 transfusions or ferritin levels above more than 1000 nanograms per deciliter. Okay. So when iron chelator, this is the maintenance therapy. Like you monitor the serum iron and liver iron you need not to monitor at a younger age. As just now discussed, it is to be done only after 6 years of age. So iron chelation in that stage is needed only to remove the excess amount of iron which is getting deposited with every transfusion. That is called as maintenance therapy. Now, what is reduction therapy? Now, as supposing the patient is not taking iron chelators properly, the iron is going to get deposited more. The ferritin is going to increase, the serum iron, the liver, hepatic iron is going to increase, and slowly even the cardiac deposition may occur. Apart from that, the transfusion is anyway going on. So the rescue therapy, reduction therapy is reduction of the iron in the tissues as well as from everyday's transfusion. And lastly is the rescue therapy, that you have not taken care, the iron chelators have not been taken properly, and now you are going to, now the child is having deposition in heart, liver, and at that time you require a rescue therapy where critical organs are affected and you require high dose of iron, especially desferal, along with other oral chelators, and that to a continuous process for maybe for a month or two. So these are the three approaches which we are going to look in. So what are our objectives? Is first to maintain the iron levels at a safe level. What do you mean by safe level? No iron in the heart, pancreas, pituitary. Ferritin levels should be maintained between 3 to 5 nanograms per ml, and the optimal liver, if at all he is beyond 5 years, you have to monitor, should not be more than 3 to 6 milligrams per gram, either by dry weight or by MRI. Gold standard you need not to do, by MRI it is more than enough. So this should be our aim to maintain the iron stores. You have to maintain the iron stores at lowest level without toxicity. Supposing if you are going to use very high drugs, in a very high doses, you may cause toxicity related to iron chelator. So you have to maintain the dose also appropriately so that you are not going to exceed the toxic doses, and also to control the labile pool. Finally, all the toxicity related to iron is because of iron labile pool, which causes oxidative stress and the injury to the tissues. So long-acting chelators, which are going to act 24 hours, have to be used. And finally, you all know these drugs has to be taken lifelong, and therefore compliance is a very, very important factor. We all know these all three chelators. I think since we have been doing pediatrics and thalassemia, we have been seeing this table quite often. The comparison of desferal, Kelfor, and XZ, that is Desirox. As per half-life, we all know the shortest half-life is desferal, 20 minutes. Quick acting, fast acting, very effective. The oldest and still the gold standard. Kelfor for 2 to 3 hours, and XZ, I said 8 to 16 hours. The Kelfor can be given IV or subcutaneous, rest to all oral. The doses differ between 20 to 40 milligrams for desferal, 75 to 100 milligrams in Kelfor, and 20 to 40 milligram maximum in Defera Cerox or XJ. Okay. So as I said, as per the half-life, the dose depends. So this injection has to be given subcutaneously 5 days in a week at least, continuously, or in as I said, in the rescue therapy, when there is a severe myocardial deposition, you can give it IV also, but IV has to be given very meticulously. The rate should not be more than 1 to 2 milligram per kg per minute. Otherwise, the child may face hypotension and rash, and therefore has to be monitored very meticulously. The main side effects of desferal is it affects the growth plate if it is given for a chronic period. If in the prepubertal age, it may cause vision problems, it may cause hearing problems. Therefore, vision and hearing has to be tested before starting desferal, and normal reactions has to be looked after. Basic LFT, RFT has to be monitored in all three agitators. Mainly deferriprone, we all know that it causes GI symptoms, agranulocytosis, neutropenia, and arthralgia. And once arthralgia is developed, it is permanently contraindicated. Deferasiros, we all know it is to be taken orally in the morning, empty stomach preferably, without any iron containing in metal container, so that it should not chelate to the container by itself. So use the glass or a plastic with a glass spoon. And nowadays, the new product that is called FCT, film coated tablets, are also available, which can be taken more frequently. It is not necessary that every time you can take, you need not to take in the morning. You can take half an hour after meals or 3 times in a day if the dose is very high. So that is about deferasiros. It is contraindicated if you are having any renal toxicities and liver problems. So basically, it is the same description which I just discussed about all three drugs: the toxicity level, the monitoring, and the doses. Okay. So all these three tables is about the same drug. So whenever there is agranulocytosis, when the severity of agranulocytosis is less than 500 neutrophils, then you have to stop the drug. Between 500 to 1500, you can decrease the dose by 50%, or else you can continue the drug. And you have to monitor for liver functions and DA. The thing is, like, Kelfer also chelates some trace elements like zinc and selenium. So if patients are having any deficiencies related to zinc and selenium, you can add that as a supplement when the patient is especially on Kelfer. So these three iron chelators has to be used in combinations. But the problem, why we have to use, we all know intensity. It is more convenient, it is efficient, the tolerance is improved, and the compliance is better. We are using more than 2 chelators, and the mechanism of action is also different. So it is better that we use a combination therapy rather than a single drug. So to start with, I'll be discussing the combination, and later on I'll be discussing how exactly which drug has to be given. So deferriprone plus desferozamine, that is Kelfer plus desferal, is the most standard combined chelation, which has got largest studies and largest experience of the use. Basically, you start desferal in the dose of 20 initially, and then slowly increase to 40 milligrams 3 to 5 times subcutaneously, along with Kelfer, that is 75 milligram per kg per day. So now why this chelation is the best one combination? You all know deferriprone, it's a small molecule which can enter into the tissues, binds the iron and brings it into the circulation, into the you can say into the plasma. Therefore, it causes shuttling of iron from the tissue into the plasma, increases the labile pool, so that this labile pool is available for deciros to be shunted. Okay, so DFP becomes free and again re-enters the cell to remove excess iron. So this is how, why deferrif, I just know in the quiz the question was asked, why Kelfer is more preferred drug in cardiac failure, in myocardial deposition as compared to other drugs. On the other hand, what does desferal does? It has got more affinity to these molecules. It will bind the molecule and excrete more predominantly through the urine. So it is shuttling the iron from tissues into the plasma, and desferal shunting the iron, making it more soluble and excreting through the urine. This is called as shuttle and sink therapy, the most preferred dual chelation, which has been proved effective. So this has been studied that even the combination has helped to improve the T2 star, as well as has improved the cardiac ejection fraction in most of the cases. The next combination could be desferal with deferasiros, that is Kelfer, XZ. This combination, you can start with XZ, that is deferasiros, the oral iron chelators. Start with 20 to 30 milligram per kg. You can increase the dose, and then you can add desferal. At least initially you can add only twice a day. Now this, why you need to add? If you are starting desferal, as I said, it was 24 hours in a day, and still why do you want to? But supposing if the patient's iron deposition is too much, like he's requiring more transfusion, the chelation is not occurring appropriately. And every person has a different bioavailability. Means I may be having the same amount of blood as other patient. I may be taking the same amount of dose, but me responding may not be same as the other patient. So every person differs. So if the iron starts still getting deposited, you can add on desferal only at least 2 to 3 times twice a day, or slowly increase to 7 times a day. Means 5 times in a day. Adjust the dose as per the ferritin levels. Now, combined therapy is very well tolerated. It has got less potential of toxicity, and it has improved in systemic iron burden. It's a as I said, it has got a very, because desferal has got a very good movement of labile iron, so it is best combination therapy. And then last is 2 oral chelators. These 2 oral chelators, though they are more commonly used in Indian scenario, because desferal availability is a very big problem, and therefore this chelator, though it has been used, but it has not been studied very effectively. So we can have more publications if at all we are using these 2 chelators. I usually resort where there are organ risk is very high and there are no safety concerns still now, but studies are still needed. Now, what should be the options? As I said, especially in Indian scenario, you can start with Deferasirox, that is Desirox. Go to the maximum dose of 20 to 40 milligram per kg, preferably early morning, empty stomach. If he's not tolerating, you can give half an hour after meals. As I said, avoid all metal contamination. If the dose is very small, dose is very high, you can give it into 2 divided doses. If the child is if he's not finding it very convenient to swallow, you can give dispersible tablets. I mean FCT tablets in 3 divided or 2 divided doses. The dose of FCT is just 20 to 30% less than the standard Desirox dose. And if at all, you monitor the ferritin every 6 monthly. If the ferritin are going high, don't believe in only one report. There should be serial measurement of ferritin. If the subsequent report of ferritin is still going high, then consider adding another drug. You can add deferiprone or Kelfer, as I said, because what I said is ideal would be adding a desferal. But desferal availability, you can see the compliance of the patients, you can see. If there is no good compliance, you can add Kelfer or that is deferiprone. Both you can continue and monitor after 6 years, as I said, then you can monitor with cardiac MRI. The combination is better. If there is a cardiac iron overloads occurring mild, then you can add twice a day only desferal, slowly increase to 3 to 4 times in a day. So even 3 iron chelators also accepted, but only if there is severe cardiac iron overload. Otherwise, 2 drugs, preferably 1 injectable and 1 oral are more preferred, or 2 orals. But in Indian scenario, if at all there is no availability, just don't sit saying that there is no IV desferal available. You can add 2 oral chelators. I'll just touch on to non-transfusion dependent thalassemia. Even in non-transfusion thalassemia, where transfusion is not a major concern, like transfusion is not often required, in them also you are likely to see iron overload. The mechanism here is because the hepcidin levels are low, the erythropoietin levels are high, so there is maximum iron absorption through the from the GI tract and getting deposited into the reticuloendothelial system. So here you will see more of liver iron overload as compared to cardiac iron overload. And some patients, though they are not receiving frequent transfusions, are also going to have iron overload. And therefore, in such children also, you are supposed to start iron chelators when the ferritin levels are more than 700 or beyond the age of 10 years. There are few new iron chelators which are still under study, but are not yet into the market. The starch desferoxamine is a drug which is synthesized by attaching desferoxamine to a modified starch, but it has got a lot of adverse effects and is still under study. There is one more the subcute iron chelator, which is hydroxybenzyl ethylamine diacetic acid, which has got twice as potent as desferal, but still under study. And GT 56252, It's one of the oral iron chelator which has 2:1 binding capacity and it's very effective, but these are yet to be coming into the market. So in conclusion, advances in iron chelator therapy have led effective drugs and treatment regime has helped to decrease the iron overload, but compliance is a very, very important factor, and you must focus customizing chelation for each and every patient in a different way based on his baseline characters and the availability of the drug. Now, let us move now to splenectomy. So I think we had covered maximum things in iron chelation. Any doubts about iron chelation? So if you start using, you keep on having problems. The steps to be taken to reduce splenomegaly in thalassemia. Now we all know, because why do we have splenomegaly in thalassemia? I say extramedullary erythropoiesis is the main, but apart from that, still iron overload by itself, hypersplenism later on causing excessive massive splenomegaly. So adequate transfusion by itself may keep your spleen in a you can decrease the size of the spleen. You maintain pre-transfusion hemoglobin as mentioned between 9 to 10.5. It can be reversed by increasing the transfusion for a short period of time. You can use hypertransfusion and try to decrease, especially when we plan for bone marrow transplant. We give hypertransfusion and decrease the size of spleen, because that is one of the very important criteria, negative factor for bone marrow transplant. And you give the good quality hematocrit. I mean, hemoglobin of more than 40 grams per bag also improves the means oxygen carrying capacity and stress on the extramedullary erythropoiesis. As possible, fresh red cells as per the availability. So all these factors, in spite of taking all these measures, the spleen size keeps on increasing. Then there might be some of the indications to do splenectomy. So don't directly jump ki that spleen, now he's having hypersplenism and I had to go for splenectomy. So increased blood transfusion requirement that prevent adequate control with iron chelator. So even if there is increased transfusion requirement, but by increasing the iron chelators, if you are able to decrease the iron overload, you need not to go for splenectomy. You try to avoid splenectomy as far as possible, especially though surely below 6 years. Beyond, supposing there is an elimination or something and where the transfusion requirement is high, you increase iron chelators. You give that hypertransfusion therapy if the spleen size is more. You can give a small dose of steroids and see if there is some suppression of spleen size. And in spite of that, there is symptomatic splenomegaly, which is accompanied by discomfort in the left quadrant or a massive splenomegaly causing a concern about his splenic rupture later on in life. Then only take a call about doing splenectomy. So I'll talk about this. So as we all know, surgically there are two methods. Open splenectomy or laparoscopy. Laparoscopy requires little more expertise, but less morbid because the hospital stay is less, shorter, and fewer complications and infections and post-op care. There is something called as partial splenectomy, where a part of spleen can be removed. But this, unless the splenectomy is required in a children who are less than 6 years, where you have to save spleen, there you can try for a partial splenectomy. But how much spleen to be removed? And the remaining part is how much is going to regrow, that nobody can predict. So generally it is said that more than 40 to 50% of amount of spleen, if it is kept behind, may improve his, may help his immune system, but that is only for children below 6 years, where you are still has to wait till he advances beyond the 6 years. For that, in emergency conditions, you can consider partial splenectomy. Splenic embolization, has anyone ever gone through or tried to do this splenic embolization? It's a so painful procedure, like we had tried to get it done in 1 or 2 patients. It is less, though it is less invasive, but the amount of pain which is there, because you are going to embolize a vessel and allowing the embolize to to function properly, so that rest all spleen gets strength. The spleen has got a capsule and it's so painful that the patient cannot tolerate that pain. Means we had tried in 1 or 2 patients, And I will never advise splenic embolization, because patient is means he is aware, and you are just injecting radiologically under the VIR guided selectively splenic vein and trying to thrombose, and it's a very big vessel, and therefore it causes lot of pain and discomfort. So in complications are abscess formation, pleural effusion, portal vein thrombosis, liver failure, and possibly may finally lead to. We had seen that these thrombus vessels have again recanonized and spleen is again become functional. So after 6 months, they were again functional. So it has never worked. So first of all, he has to undergo so much of pain, and still it has not worked. So failure of embolization is very common, and the complications are very severe. So this is not a very preferred method of splenectomy. It's better to go for laparoscopy. As we all know, I think this diagram has been famous since the time we studied about splenectomy. He should be immunized at least 2 weeks before, but preferably 4 to 6 weeks before a splenectomy with pneumococcal vaccine. PCV13 should be given 4 to 6 weeks prior to PCV23, because giving PCV13 first and then PCV23, the common 10 to 12 antigens, the take is very good. So preferably give PCV13 first, wait for 4 to 6 weeks, then give PCV23, wait for at least 2 to 4 weeks, and then if it is a plan. If it is not a planned surgery, he can go within 2 weeks of surgery for immunization and repeat immunization after 1 month. So influenza vaccines to be given 4 to 6 weeks. Again, Hep, and pneumococcal, these are two vaccines again to be given along with PCV. And influenza vaccines, if it is available, yearly has to be given for all thalassemia children. So as just now, as I said, should be delayed beyond 5 years. And because we are removing spleen, the child is now not protected with capsulated organism. Therefore, he requires chemoprophylaxis 125 milligrams of this Pentids, or alternate you can use amoxicillin for children less than 12 years, or 250 milligrams in children 2 to 5 years. And alternative drugs if he is sensitive to penicillin group of drugs. Post-operatively, it's not so easy. In thalassemic patients, post-operatively, the platelets rise more than 10 lakhs to 20 lakhs. And therefore, whenever there is a rise of platelets more than 10 lakhs, they should be supplemented with low-dose aspirin for prophylaxis, and for an antiplatelet prophylaxis, as the chances of pulmonary embolizations are very high. So as I said, hypercoagulability has to be protected. Pulmonary hypertension has to be monitored regularly in these patients. And I said, once you have removed spleen, don't feel that you have removed maximum amount of iron. You have removed one of the storage of iron. Therefore, now the iron is now going to get easily deposited into the other organs, especially the liver, heart, and pituitary and endocrine organ. So, although more, the chances of liver means organ damage is more when you have done splenectomy. So both sides, one is infections are more, and though deposition in other organs is accelerated because of splenectomy. So keeping in mind all these complications, we are all supposed to take care why splenectomy and indications of splenectomy. Thank you.
We have, she is a very well experienced teacher also, and she gave a lot of information about, I just, apologize for ma'am, I didn't introduce her properly. She is also recognized authority in hemoglobinopathies, plastic anemia and bone marrow transplantation, and it is a privilege to have a final teacher with us. Ma'am, one question for you.
Yeah.
Can the chelation therapies, like the reverse endocrinopathies which happen after iron load to a certain extent?
See, thyroid can be reversed, but those pituitary and all, because once the damage, there is a fibrosis. Once the iron gets deposited, there is a fibrosis of that organ, and the functionality of the endocrine system is affected. So, if like in pancreas and thyroid, when deposition is in early stage, and if you treat, you may reverse. But if the deposition is too high, you are going to cause the fibrosis of the endocrine system, and then the reversibility is not complete.
How frequently should we immunize post-Splenectomy patients?
So as I said, one is before immunization, then afterwards only Hib you need not immunize, but PCV and meningococcal has to be taken every 5 years later.
Any other question?
Splenectomy, which are the ideal patients for the splenectomy in your experience?
So patients beyond 6 years, preferably, as I said, because we had 1 or 2 patients who had, as just like Dr. Dheeraj said, they had elimination with first transfusion, and it was very difficult for us to push till 5 to 6 years. So such patients, we had given rest all the treatments, just waited for him to complete 6 years, but preferably beyond 6 years. As I said, more than even after giving hypertransfusion, taking care of ion chelators, excess iron overload, ion deposition can also causes spleen increase, right? So you give him ion chelators properly, give him hypertransfusion properly, and in spite of that, there is hypersplenism and massive splenomegaly causing discomfort. Then you had to go for spleen. And might be that his transfusion requirement is so fast because of this hypersplenism that he may be requiring weekly. The transfusion requirement, if you calculate in the chart, is more than 260 ml annually. Then he goes for splenectomy.
So what is the percentage of patients, like 100 patients, how many patients in your center?
So in our center, if you see, we have 300 patients, but the patients who are more than 25 years and not taken chelation properly and transfusion, they have not maintained pre-transfusion hemoglobin properly. So their spleen has increased and it has gone into hypersplenism. So in spite of giving excessive transfusion, means hypertransfusion and giving iron chelation, we wait for 1 year. So whatever it is, that I said the iron chelators, we increase to the dose. In spite of that, if he's not responding, then he has to.
Ma'am, platelet count, any blood parameters we consider while doing spleen?
During while spleen, we know, because see, because of hypersplenism is likely to go low in HB as well as counts as well as platelets. As soon as you clamp the splenic vein, the platelet counts are going to improve. So low platelets is not an indication. Only for anesthesia fitness, you have to keep beyond 50,000, which you can do half an hour before, means at the time of surgery, because you don't want a bleeding at the surgery. That's it.
Thank you.
Thank you very much, Dr. Sujata, and thank you very much, Dr. Sandeep and Dr. Gokul, for chairing this session. I now invite Dr. Shweta Bansal ma'am to say a few words.
I think with this talks, we have covered majority of our thalassemia, the complications and everything. We were planning to have one panel discussion also, but 2 panelists could not make it today. So I think we'll just let it go. But we have Mr. Ketan from Arpan Blood Bank. He's still there. I think yeah. Sir, we would like to hear from you, like what are the difficulties you face and what contribution you need from the community, from the doctors to have a smooth services. Right?
Dr. Ketan is my son. He is with us.
Sorry.
Regarding the blood donation camp, madam.
Yes, yes.
In our setup, we had a good contact with all these institutes or NGOs. So particularly Mumbai, we are acquiring the whole Mumbai area for the blood donation camps. And in this camp, actually we don't have any major difficulties. So we are doing the camps regularly, and we are having 120 patients for thalassemia.
and on this duration, we are giving transfusion to all patients free of cost. The other patient monitoring we are doing in terms of only ferritin rate. Ferritin we are monitoring, and the other I learned today only that we are not doing. So this is about our excellence. Thank you.
Thank you so much. Dr. Anil Shah, we would like to hear from you also. Mr. Anil Shah is he is taking care of his son also, who is affected with thalassemia major. But the most important thing is that he supports us in various other activities also, and he's always there for any help for the thalassemia patient. Thank you so much for that. And
Thank you, ma'am. As Madam said, I'm a parent of thalassemia major child. My son Nimesh is 38 years old. He's taking transfusion in this hospital. Doing well actually. I'm blessed by the God because since beginning I got the experts doctors, means help from the expert doctors taking care of my child. As a parent, you have to face a lot of problems in your life. When Nimesh was detected thalassemia major, he was 4 months old, and it was in 1987. That time we were told that these children, they don't survive beyond 8 to 10 years old. That is. So even one of the doctors who was treating him, he suggested that if you want to bring up this child, it's very difficult. You can leave this child. You can decide now, because once the child is very small, and as the child will grow, then your affection will, and then you will be in a very difficult situation. Because you won't be able to afford the treatment, you won't be able to grow properly, doing proper treatment. So that was a big challenge actually. But we decided we will take up challenge. And fortunately, we got a good hospitals, good treatment, good doctors, and he's doing well. I tried bone marrow transplant when this facility was not available in India. I decided to go to Italy, Pisaro, Dr. Guido Lucarelli. Unfortunately, his HLA typing was mismatched, was not related. Siblings के तो हिसाब से नहीं हुआ, but mothers के साथ में हो रहा था. Then at that time, Dr. Mamun Chand, he started bone marrow transplant in Bangalore. So I think for one of the meeting, Dr. Mamun Chand was here. So Dr. M.K. Agarwal called me. That time he knew because he was supporting me for bone marrow transplant. He called me at his clinic, and I met Dr. Mamun Chand. He called me there in Bangalore. But unfortunately, they found one mismatch with mother. BR locus was not present. So that bone marrow transplant. This was when he was 7 or 8 years old, I think 94, 95. So then we decided we will forget about bone marrow transplant because after Mamun Chand explained me this is not admissible and you have a conventional treatment available. So please focus on the conventional treatment. You can grow your child very well. So we decided we will not. And now we are hearing about genetic engineering, but I don't know. But for Nimesh is doing well. He is living a painful transfusion, but he is happy with the transfusion. Even if now I tell him, say, we want to try another treatment, but he will say, no, this treatment is okay. And now I am really blessed. He is taking transfusion in Asian hospital. It's the best treatment. I have gone to many hospitals, but this one is the best place. He is very extremely happy here. He's maintained his health really well. I think he is the first thalassemia major child in the country that was we are told. He did B person. There were many other students, other children did it, but he did it some 15, 20 years back. He did B, then he did MBA. He's working with a good company. He's a senior manager. He's 6 inches taller than me. His growth is very well. He's monitored well. So, thank you.
Thank you so much, and it is very heartening to hear this kind of success story because this gives a lot of hope to many, not only to the patients, even to the doctors to take a good care of these chronic diseases and patients. Anybody else?
And one more thing, I think he is the first child who started Desperal, this Chelation, when he was 1 year old. That time it was not means it was means even today, doctors are saying that after 3 years,
Yes, yeah.
after 12 transfusions, we should start. But that time there was conference when he was 1 year old, there was a conference in Thalassemia hospital, and I met Dr. Mary Petro. And she told me to start transfusion now. When I was discussing that, I consulted my doctor, Dr. Jaju in Central Hospital. He said no, 3 years के पहले नहीं कर सकते. Then on the third conference, Dr. Jaju attended the conference, Dr. Mary Petro arranged their meeting and he convinced that he started. So right from the beginning, the serum ferritin is around 1,000. 1,000. So I think he's well monitored child. And he is happy he is receiving transfusions very well compared. So I'm happy with his statement. I'm happy with all the doctors and whatever experience I had. Thank you.
Example that early chelation and maintaining how it can improve it long.
Yes. Yes. So not only blood transfusion, chelation is a very, very important part of management of thalassemia patients.
Thank you so much.
Thank you. Anybody else in the audience would like to share their experience? Dr. Sujata, there is one question on virtual this thing.
Yeah.
So how long low dose of aspirin should be given to the patients with thrombocytosis who underwent splenectomy? And when to initiate aspirin in such patients? Thrombocytosis, how long it persists and how to follow up such patients?
So, if the thrombocytosis is post-splenectomy, and some patients, they may not have platelet more than 10 lakhs. So, but some patients who have platelet between 5 to 10 lakhs, you just have to maintain their hydration and monitor them for any thrombosis. But then if patients' platelets are more than 10 lakhs, we should not prophylaxis of aspirin, 75 milligram per kg per day for quite a longer time, unless he has to be taken for some surgery or some he has to stop a week before, or else he has to be on control.
So if the counts come like between 7 to 8 lakhs, do you stop or you still
And
continue?
how frequently you're going to monitor that?
Like, I mean, they do CBC like for the blood transfusion.
And how are we going to come to know that he is going to more than 10 lakhs? So it's like a prophylaxis how in hard is your day. It has to be continued.
So you don't stop if the patient platelet count is less than 8 lakhs. Okay, thank you. I think anybody else wants to share their experience? Anybody would like to say, add how they felt? Sandeep, you have not said anything. Though you share the session, you would like to hear from you something.
It was a great revision. Actually, it brings back my residency days at Vadia. I used to monitor all thalassemia patients. It brings back everything every Monday morning to collect all pre-transfusion sample, to maintain a diary. It was a quick revision, and I think so we should have such basic, very important topic, because in today's super specialty area we cover all the hi-fi things, but these basic things are very important to revise. So it's like I was very glad to attend it, and it brings back my residency days.
Thank you so much, Sandeep. We are very
It
glad
was
to
really
have you.
very well covered, all basics from, I mean, the day started with how to, what is a prevalence, what is a problem, how severe is a problem, and monitoring of the complications. And last and not the least, I mean, the thalassemia topic is incomplete without talking about the chelation and splenectomy, role of splenectomy. So that's well covered. And again, the sustainability of the stem cell transplant program, very well covered.
Thank you so much. I think with this, we'll end the meeting, and thanks to everyone for coming today and attending the conference on this Sunday, because I know everybody has to give from their family time, but still they had come, and I'm so glad. I hope you enjoyed, and all those attendees who have been here, they will get the booklet. We have made the booklet of all the proceedings, and we'll share soon. Thank you so much. Sorry, we have the prizes of the quiz winners are there. ABC. ABC was in the virtual. So, yeah. So you can announce anything.
So the quiz winners, third prize, we have somebody who's present here, Dr. Charita. Can we have you on stage, please? Congratulations. The second prize goes to Dr. Burhan, who's also present here. Heartiest congratulations, Dr. Burhan. And the first prize is backed by Dr. Bidita Podel, who's present with us virtually. So we'll give her the gift virtually. Thank you so much, everyone.